So is my screen visible, sir?
Yes.
Yeah,
Yeah.
yes.
Yes. Uh, so the topic that I've choose for this today's operative technique is pancreaticoduodenectomy, in which we will discuss about the perioperative and intraoperative principles. So uh, basically, pancreaticoduodenectomy is a complex surgery and the requires assessment and uh, optimization of the patients is very important in this case. And then we proceed with the look for the resectability and staging, and then go through the standard operations. There are certain intra-op principles, and followed by the reconstruction as well as the post-operative care.
Yeah. Only thing is that you have to decide the resectability
Yes, sir.
before you go on to preoperative optimization. The
Yes, sir.
decision to resect has to be taken before, right? It's a
Yes, yes, yes,
diagnosis
sir.
is first, right?
Yes, sir. Yes. So, regarding indications of Whipple's procedures, mainly we are doing for the malignancy cases, especially for the periampullary malignancy, which includes the pancreatic head mass, distal cholangiocarcinoma, ampullary mass, and duodenal adenocarcinoma. We are also doing for the pancreatic ductal adenocarcinoma, and in selected benign cases, pre-malignant cases also, we often have to do for go for the Whipple's procedure. That includes pre-malignant, includes IPMN and neuroendocrine tumors. Sometimes in benign conditions like patients with chronic pancreatitis with mass formation. So those patients and in some rare cases in traumatic pancreatic trauma, also there can be indication for Whipple's procedures. So these are the indications for Whipple's. Regarding pre-operative assessment and fitness, this, as sir told, once we have committed for the like patient is resectability has been confirmed, then we have to always go for the pre-operative assessment and the we have to look for the fitness and nutrition status of the patients. Since it is a complex surgery with associated with significant amount of morbidity. So preferred in these cases are like patients with performance status between ECOG 0 2 are preferred, and once the ECOG is more than 2, then that predicts poor tolerance to the procedures. So similarly, in the nutritional status, there are a lot of parameters in which we can assess the patient, and one of them is the subjective global assessment, in which we take the history of the weight loss, any significant, like especially if there is a more than 10% weight loss in the last 6 months, or more than 5% weight loss in the last 1 month, and the in dietary intake in especially in the last few weeks, mainly in 2 3 weeks, and patient having some GI symptoms for more than 2 weeks, and the functional capacities, all these forms the assessment of the subjective global assessment, and based on that we can categorize in class A, B, and C. So class A includes the well-nourished patients. In this, we can directly proceed with the surgery. In class B, in which the neutral status is moderate, in this requires prehabilitations, and usually in 2 to 4 weeks, we keep these patients in prehabilitation group, and we go for the nutritional. We counsel regarding the nutritional intake, especially the high protein intake. And also motivating them for the exercises, rehabilitation exercises, especially like chest physiotherapy, incentive spirometry, and there are structures exercise also which are available, and we make patients to follow those for next 2 to 3 weeks, and then again we recess in these groups, and then we go for the surgery. And this in group C, the patients are usually severely malnourished, so these patients requires proper assessment, and these patients are usually unfit, not fit for the procedures. So the root cause of the malnutrition and the poor functional status has to be addressed, whether in terms of whether there is a poor intake or any symptoms like patient can have sometimes gastric outlet obstruction. that might be the one of the reason. Or patients like in background of chronic alcoholism. So those issues has to be addressed. Then only we can optimize the patients and then can proceed for the surgery.
Suppose your patient is overweight, how will you proceed? You're planning for the Whipple, but patient is overweight, have obesity.
You
Do
see.
you, yeah,
Uh, so we can ask the patient like is these patients also need to be involved in the prehabilitation group, and we can give them subjected to the disease status. We can give them 2 to 3 weeks of nutritional assessment in which we can take a opinion from the dietitian and what things can be changed in the dietary. Similarly, doing exercise and whatever possible weight reduction measures can be done. So we can keep them in this prehabilitation group, and sometimes the obesity can be related to the disease also. So, like in patient in like a pancreatic adenocarcinoma patient can have diabetes. So that might be one of the reasons. So that also needs to be addressed, like optimization of the blood sugars. So in that also we can optimize the patient.
okay, proceed.
Yes, sir.
Yeah.
So once we have like uh, assess the patient, the workup requires the pancreatic protocol triple phase CT. That is the in which we decide among the resectability of the underlying pathology, and this this mainly gives whether the patient is resectable or whether it's a borderline resectable or it's a locally advanced tumors. So based on that, like a patient, if it is a resectable, then we can upfront go for the surgery. If it is a borderline resectable, then patient has to go for the neoadjuvant therapy followed by reassessment, then surgery. And if it is a again locally advanced tumor, then patient has to go for systemic therapy and followed by reassessment. And there might be chances the patient will convert into the resectable form. So that state that then again we can go for the surgery. And regarding pre-op, pre-op diagnosis is not always mandatory in cases to plan for the Whipple's procedure, especially when there is a clinical background and clinical background means in his clinical history suggestive of malignancy, other tumor markers like CA99, these are elevated. So in those conditions with the background of the clinical assessment as well as the biochemical assessment, we can go directly for the surgery rather than having a pre-op tissue diagnosis. And MRI with MRCP can also be done, but however, preferred in our center is we go for the pancreatic protocol CT. And in certain cases where there needs to be biliary anatomy has to be delineated, on those cases, we or in some reasons that is not equivocal or is not conclusive in CT. In those cases, we can go for the CMRI with MRCP. And CA99 is also one of the supportive this is tumor markers. So again, this has to be interpreted along the bilirubin because high bilirubin can give falsely elevated CA99. And some patients might need staging CT that can be in that might need PET CT also, especially when there is high CA99 value, especially more than 500. If CA99 is more than 500, in those conditions, so we might have to go for the PET CT and assess the staging of the patient.
So
Even
can you
CA,
tell us about situation? Sorry, can you
yeah,
tell us
yeah,
about
yeah.
Shikhar? Can you tell us about situations where the getting a biopsy becomes mandatory?
Sir, if patient is not upfront resectable, so if patient is planned for neoadjuvant therapy, in those conditions, we have to get a tissue diagnosis before going for the chemotherapy. Similarly, there can be some conditions in which there is a doubt between whether it's a underlying benign disease, like especially in the autoimmune pancreatitis, that is the benign conditions in which the patient might benefit with the steroids rather than going for such a morbid Whipples. So in those conditions also, we can go
Yeah.
for the pre-op biopsies.
So although we insist on no histopathological diagnosis, these are situations where you should be aware and actually go to that extent to get a
Yes, sir.
tissue diagnosis. Okay,
Yeah. Yes, sir.
please carry on.
Yes,
And
sir.
here, how will you assess the chest? You have not mentioned whether you do the CT, include the chest, yeah, or do the chest X-ray. And second thing, suppose you're just planning your surgery and you're optimizing your patient, you give all your effort, you start
Yes.
nutritional supplement, everything, and patient is not getting well, is not getting the weight. What you suspect and how will you proceed? You do everything.
Yes, sir. So that might be possible in the condition with the if the patient is having aggressive biology of the underlying disease. So despite of giving all the effort, but if the biology is poor, it's aggressive tumor, the patients will still not improve on the prehab group. So those patients mainly uh, will mainly benefit with the from
What
chemotherapy
you'll
followed.
do? Yeah, that could be the reason. But suppose you're giving all you have done, the patient is not getting weight. Then I have some suspicion that the patient may have a hidden kind of metastasis. I look for the tumor marker CA. CA 99-9 even can increase in the situation where the patient have a cholangitis and
Yes.
jaundice also. Should not have a jaundice. Then you says and look for the
Yes, sir.
CEA. Sometimes spontaneous raise in the CEA and patient is not getting well by supplementing your nutrition, protein, everything is losing weight, not improving. You should have a suspicion of the metastasis. Then your last, you have written the CT PET scan should be
Yes,
done,
sir.
I think.
Yes, sir.
Go ahead.
Yes. The
Question to you
next,
is like your topic
yes,
is operative techniques. So why are you just
Yeah, yeah.
putting time on this? This is something which comes in the case discussion.
yes,
So you should quickly
uh,
move ahead. Otherwise, there won't be any operative techniques.
yes. Um, so we'll decide the resectability based on the NCCN guidelines, in which we divide into resectable, borderline, and locally advanced. And,
This we know. Yeah, go ahead.
yes. Preoperative biliary drainage is not a routine procedure in case of patient planned for Whipples. But the patient, there can be certain indication like a patient is in
So now you
cholanditis.
have to tell me in operative techniques, how does preoperative biliary drainage affect your surgery? These we know.
Yes, sir. Uh,
How does operative technique is affected by preoperative biliary drainage?
so with the a patient is having a pre-op drainage has been done, then the chances of outcomes like especially wound dehiscence, infection,
Intraoperative,
especially
intraoperative.
intraoperatively, suppose the patients had undergone metallic stenting has been done. So especially if it is not uncovered stents has been placed. So that
Is
usually
that the usual? Is that the usual scenario that uncovered stents are placed?
usually covered
So
stents only are
mostly,
placed.
mostly the stents are placed are plastic or the covered stents. So you have only
Yeah.
one line to answer that. Na?
What happened whenever you placed a stent? What happened around the tissue? What happened with your dissection?
So basically, when you have a preoperative biliary drainage, the HDL dissection can become tough. That is why you have to selectively drain these patients.
Yes.
Go ahead, next slide. This is done.
No.
Next slide. Next.
Yes, sir.
Now so how will you plan your surgery?
So once the resectability has been confirmed from the we'll see the patient patient baseline tumor biology as well as resectability on the CT, then we'll go for the surgery. In certain cases, especially when there is a equivocal CT finding or there is a high CA99 values, then this patients requires staging laparoscopy in which we have to detect, rule out any liver mets or any occult peritoneal or omental mets are there or not. And
So basically, why have you put this point staging laparoscopy when? In all cases or in only selected cases?
so in selected cases, we have to do so.
So you have already given the point. In body tail tumors, all cases usually done, and
Yes, sir.
otherwise it is high CA99. And in periampullary cancer, nowadays every case laparoscopy is done.
Yes, sir.
So role of staging laparoscopy is over.
Yes, sir.
Will you
If we
go
are
for an
doing,
open Whipples? Will you go for an open Whipples or a robotic or a laparoscopic?
subjected to availability, robot. If robotic is available, robotic outcomes are promising in the recent studies, sir. So, uh, like
Why do
open
you
will be
think
reserved.
robotic is superior than open?
Sir, robotic mainly dissections, the movement and the tissue planes dissections in the robotic surgery are more precise in comparison to the uh, open
No,
and
I,
laparoscopic surgeries.
I'm just watching the way how people deviate with the mere mention of minimally invasive techniques. I think the standard surgery is open. So just mention open. Okay. And
Chalo.
don't deviate
Yes,
just
sir.
because somebody's prompted you कि minimally invasive available है करोगे क्या नहीं करोगे. It's not necessary.
On your topic,
Okay.
yeah.
Yes, sir.
Okay, go ahead.
And he fell asleep.
Uh, so the operation roadmap will be we'll first explore, then we assess for the resectability, then cauterization. That will be sometime with the artery first approach. Then we'll decide about the resectability and the point of no returns. Once we have committed that the tumor is resectable, then we proceed with the resection and then the reconstruction.
Will you mobilize the right colon, right flexor, or
So
directly you just start doing the cauterization? What is your first step?
first step, like skin incisions. After that, once we have opened the abdomen, then uh, we'll do the cauterization, sir, extended cauterization, and
What
try.
kind of the incision you like to do, and how will you decide what incision should be given in that patient? There,
So if patient is thin built patient, and then we can go for the midline incision, sir. And if patient is moderate to obese patients, the bilateral subcostal incision would be preferred in those patients.
go ahead.
Yes, sir. So once we have given the skin incision, can be midline or bilateral subcostal incision, then we'll do the cauterization, that's extended cauterization. And before resecting anything, we'll just first rule out any mets is there on, whether in the liver, we have to look for the on the liver, any omental or any peritoneal or any ascites that is doubtful for the like metastasis. So once that METS has been excluded, we assess for the resectability. So we have to do, we go for the cauterization of the duodenum, in which we expose the IVC till the left renal vein. And uh, then we look for the SMA origin. And based on the SMA, we will know whether the tumor is resectable or not. So, and then once the resectability has been confirmed, then we go for the
So what are the endpoints, Shikhar? What are the endpoints of resectability? That you say that this patient is unresectable. What findings, apart from metastatic tumor, what are the
yes, sir.
couple of 3, 4 findings which you see and you say, okay, I will proceed in this case?
Sir, if SMA encasement is there, sir, then
No, that is
what the
SMA encasement you do not see
Yes.
on operative technique.
Before,
That is seen on CT scan. Na?
yes, sir.
You have opened
Like
the patient, you have seen distant metastases are gone. What are the
yes, sir.
findings which you should look before you go on to do anything, what you say, point of no return?
Uh, so we'll see the vessel involvement, whether any like artery and vein, both SMA and SMV, we have to see whether
Because in
uh,
interest of time, I will tell you that what you have
yes, sir.
not mentioned is when you tell that thing, it should be there whether you looked at the root of the mesentery at the DJ flexure, whether there was a nodal disease or not. One point. Secondly,
Yes,
you should always mention when you're talking in operative techniques, when you lift up, whether the mesocolon is being involved or not. These are going to be a telltale sign whether you are going to find that. Because reaching to that stage where you will say that SMB, SMA, you might have transacted the pancreas or something like that, right? And thirdly,
yes,
but
sir.
when you told that you will do an extended cauterization, you should be mentioning you will be
Yeah,
able to see the lift the tumor and feel the pulsation of SMA. We know, all of us know that it is unresectable or resectable in language. However, these are the
yes,
objective points when any student should think about and write and speak in exam, which will proceed your viva in a smooth form. So this
yes,
is the 3 points which you keep in mind, and then you feel that local resectability, likely this tumor is resectable. Go on.
will you
yes, sir.
like
Is it?
to
I'll
create
just
the tunnel?
come in. Sorry, please
Yeah,
go
yeah,
ahead.
yeah.
Yeah, no, tunnel actually, Dr. Ashok, a tunnel would be coming later because that will be requiring more dissection. These are the posterior things which are the first 2, 3 steps,
Actually,
because
here
for
the
the
we are
students it's
discussing
important
about.
that,
Yeah,
yeah,
yeah. Here the because you already have discussed so many things, whether the patient is resectable or not resectable, then this always come whether you have a intact tunnel or not.
okay. No, what I mean to say is that comes like this would be difference between, he should be pointing out like if there is a periampullary tumor, this is sufficient. However, if the patient is cEAD pancreas, this added point will be coming
Yeah,
first before
definitely.
you divide anything. So you should be basically, when you talk about Whipple, you should say the two couple of indications. One is periampullary tumor and second is cEAD pancreas.
Yes, sir.
Go ahead.
Okay, Shikhar, one more thing. You straight
Yes, sir.
away talking about artery first approach. It's okay that it can be done as a routine, but most
Yeah.
people don't do it routine.
Yes,
You
Yeah,
sir.
have to
yeah,
choose which patients you want to use the artery first approach and which patients you do the conventional standard approach.
yeah.
So where would you actually require the artery first approach?
So especially when we are operating on the borderline resectable tumors, or patient who has already underwent neoadjuvant chemotherapy, and now we are operating on those. So in those cases, we have to go for the
Yeah.
like
So
SMA first approach.
be clear in your mind that artery
Yes,
first technique is not always necessary. It can be
yes, sir.
used for certain situations. And the third is a anatomical anomaly where the accessory artery, right hepatic artery,
Yes,
is
sir. Right
arising
hepatic.
from the SMA.
Yes,
So
sir.
these are the
Yes,
situations where artery first approach will help you. Okay,
yes, yes, sir.
Go ahead.
go
Yes, sir.
on.
Yes, sir. Next, we'll proceed with the opening with the lesser sac, and then once after lesser sac has been opened, then we'll dissect along the we'll identify the gastrocolic trunk, and that gastrocolic trunk will ultimately will help to identify the SMB that at the inferior border of the after the inferior pancreatic border, and from there we can start tunneling. We can start the tunneling from the inferior border of the pancreas over the SMB, and then once this has been inferior tunnel has been done, so now we go shift to dissection towards the
Here,
towards
one thing.
this.
do you, for making a tunnel, is it always that you don't dissect in the HDL and you start your tunnel?
No, sir. From superiorly, we have to come after dissecting the
So
HDL part.
basically, you should be telling that inferior part, you have done the dissection, you have located the SMV, then you
Yes,
will
sir.
also continue with the upper dissection, because if you try to do tunneling without doing the upper dissection, there is likely, if there is bleeding, you can't control that or you have problems, the loss of
Yes, sir.
planes.
Yes, sir.
Continue.
Yes, sir. So this HDL tissue dissection will begin with the cholecystectomy. Then will uh, skeletonize the all the CBD, the hepatic artery and portal vein. Then we'll
So
divide the
what level of the dissection? How will you continue your lymphadenectomy? After
the
cholecystectomy, you will
yes, sir.
go along the in the HDL. Do you
Station.
start right from the hilum, or you find a point of where you go ahead with your dissection for an en bloc?
So below the cystic duct insertion, like
Just above the cystic duct insertion, you will continue your dissection,
dissection. Yes,
and
sir.
not from the hilum. That is the thing in Whipples. And then you
Yes, sir.
go from the cystic duct onto the right hepatic artery and towards the common hepatic artery.
The best thing
Because
is
Yes,
this will,
just to confirm your tunnel formation is completed, because already have said you should start from the inferior. You just check your tunnel is could be
yes, sir.
formed. And superior
Yes,
dissection is also important. The main artery, hepatic artery, and the branch GDA, and the border of the superior border of the pancreas. This triangle
thank
has to be clear, because if you're not clear that triangle, you may not go through the tunnel. So you
you.
just
Yes, sir.
confirm you have make your tunnel properly. Suppose you have done all the dissection, all the lymphadenectomy have done, but you have a problem in creating the tunnel. So
Yes,
first you, for you only, although the experienced people can divert their decision, but you should learn to first you complete your task before doing
yes,
all.
sir. Yes. So continuing the lymphadenectomy, we'll remove the 12 station 12 lymph nodes, and then scrutinize the CHA, and we have to do the GDA clamp test, GDA clamp test, and once the perfusion of the liver is confirmed, then we'll go for the GDA ligation, and then next we'll do the transection of the either it can be a classical Whipples in which we do the transection of the distal stomach, or it can be a pylorus preserving pancreaticoduodenectomy in which we go for the we'll transect at the level of the D1. Then once this stomach or duodenum has been dissected, then we'll go for the uh, division of the distal jejunum, that is the distal to the ligament of the tris. Now, once we have resected proximally at the stomach or duodenum and distally to the jejunum, now we'll go for and tunneling has been completed. So we'll loop the the tunnel that we have created, and we'll divide the pancreatic neck over the SMB and portal vein confluence. And uh, once this has been
How will you divide? How, as you just create your tunnel, you start dividing the pancreas? What precaution you'll take? What routine B you're doing?
Sir, we'll take hemostasis sutures and both like inferior and superior border of the pancreas, and with the help of either we can use the harmonic energy source to divide the pancreas and to divide the pancreas, sir.
What is the problem with dividing with the harmonic? Will you like to divide with the harmonic or some other?
Sir, we can go for the harmonic, but we have to be we have to be careful while we are dividing the pancreatic duct, and especially in that part, we can use directly we can use the knife to divide the duct, and remaining the pancreatic parenchyma, we can still continue with the dividing
When
the
you have
harvest.
enough size of the duct, you may not have a problem. The tiny
Yes, sir.
duct, very small duct, you can adapt all
Uh,
these.
yes, sir. So once this pancreatic neck has been divided over the SMB and portal vein, then we next go proceed with the dissecting of the uncinate process from the SMB portal vein and the SMA complex. So it requires meticulous.
When you're dissecting the incident, what you expecting? What the structure, what the vessels could come in across when you are dissecting the SMA? So what is in your mind? You already have
So
divided the pancreas, and
yes,
now
sir.
you are dissecting the incident.
Yes, sir.
What precaution? Because it's very crucial stage
Yes,
of.
sir.
Mm.
First jejunal vein will be there, sir. That and similarly, multiple tributaries will be coming from the uncinate. So that has to be meticulously either clipped or can be ligated, and then we can divide the uncinates.
So for jejunal vein going behind towards the proximal part of the jejunum, giving some branches to the pancreas. Yeah. And what
Yes, sir.
best branches you like to see here?
So inferior pancreatoduodenal where arteries vessels will be there, sir. So those has to be ligated.
कौन सी arteries on which kind of two main
So
arteries?
and
Yeah. Two different system, different trunk, and two arteries.
the anterior and posterior inferior pancreatoduodenal artery will be there, sir.
Hmm. Yes, ठीक है.
And
And
once the yes, sir.
So what
what?
you're doing now is you're dissecting on the, you have to dissect on the lateral border of the SMA. When
Yes, sir.
you're removing the uncinate, you have to hold it in your left
And,
palm.
and yes,
You have to
yes, sir.
pull the specimen towards the lateral thing so that you can feel the pulsation in the SMA, and you have to work on the SMA
And then
as you go up in the cephalad direction. That is the
yes, sir.
way you have to do, right?
Yes,
After you
yes,
have
sir.
ligated the IPDA, you'll get the plane in a better fashion, and you'll be working on that plane towards the root of the SMA. Okay?
Yes, sir.
Of
Yes,
course,
sir.
And well,
somebody has to retract the SMV above with the eyelid
yeah.
retractor so that you can see the plane properly, right?
Yes, sir. Yes, sir.
And very excessive retraction also may not be required because sometimes you may be new in doing surgery, you may have an injury in the SMA also. Also, very careful about the abnormalities. The
Yes, sir.
artery, right hepatic artery may be arising from the SMA.
Yes, sir.
Should all have the information before doing
Yes,
the dissection.
yes. So after once we have resected the pancreas, then there might be a situation where we have to go for the frozen section, especially if, to look for the margins, especially in pancreatic neck or in the bile duct margin, if we have to go for the RG resection. So that might be needed in certain cases. After once the resection part has been done, then we proceed with the reconstruction part. So reconstruction
Shikhar,
mainly is
which patients do you send for frozen? All cases at your center?
no, not routinely, sir. We're
So
not
which
routinely,
which
sir.
which patient? When do you suspect involvement?
Uh, so when like in pancreatic duct head of CA head of pancreas, sir, and if it is a large tumor and that the pancreas where we have divided, if we are doubtful about the margin, in that condition we have to get. Similarly, in
No, that is
periamplar,
true. But when do you get doubt?
like on intra-op only if we feel that there is a R1 resection, then so,
ठीक है, continue.
yes,
So you may have a three kind of situation. You already have the suspicion that the tumor may involve the ducts.
yes, sir.
Second, you have a lot of kind of reaction. You could not differentiate whether this is tumor or inflammatory reaction. You have a doubt in your mind. And
Yes, sir.
third situation could be the IPMN. You're dividing, you still have some suspicion that the duct may be involved. Even
Yes, sir.
still, you may not have the confirmation. That
Yes,
in these situations, you should adapt all these, um, mm,
yes.
yeah,
Correct,
doing,
correct.
Frozen.
And
Yes,
also the other side, which you talked about CBD, similarly in CBD, if you find that your thickening is extending, again the
yes,
same
sir.
thing. If you are having a doubt that if the inflammatory or thickening involvement is going higher, you do not have a smoothing, then you
yeah.
send. So you have to
Yes,
speak these points. All 3 points which Dr. Ashok told were the relevant points where frozen section definitely helps.
yes, sir.
At times, it might also create a doubt in your mind. If they say that there is some atypia, then will you
Yeah.
re-resect the whole of the pancreas? So that we have to decide case to case basis. Go ahead.
Yes, sir. So once resection part has been done, now we go for the reconstruction part, which includes the PJ or can be PV, pancreatogas.
Now, Shikhar, what are the potential sites of bleeding when you are completing the
Yeah.
resection in the Whipples? 1, 2, 3, 4. Right from the beginning, what are the areas where likely one is going to encounter bleeding, and then you can tell how we can prevent that.
So first most common is the bleeding from the gastrocolic trunk while before proceeding with the
Correct.
tunneling. So that is the
Very
most
good.
commonly injured. Then
So how can you prevent that?
so dissecting more of the proximally and identifying the tributaries of the gastrocolic trunk. So like one by one we can ligate those tributaries and then proximally we can trace the trunks. So
No, the
that
important thing is that your assistant you should tell, especially in obese patient, kindly don't give too much of traction.
Yeah.
You have to
yes,
tell something which is related to technique. You cannot just talk about. Everybody knows that we have to prevent bleeding. So what
yes,
we
sir.
want here you to know that you should avoid excessive traction. So the shearing injuries, when you release, suddenly you will find there is bleeding. And second
Yes,
thing
sir.
is that it is good to ligate the anterior pancreatico superior duodenal vein branch, which is joining because for this, what is the anatomy of gastrocolic trunk? How is it formed?
So it is formed by three vessels, sir. I mean, the right colic vein and then anterior uh, anterior superior pancreatoduodenal vein, right colic vein, and
मिडिल कोलिक वेन नहीं आती है उसमें.
yes, uh, yes, sir.
And
Middle
sometimes
colic.
it's very helpful to knowing the anatomy because sometimes you may not get the tunnel. So you
Yes, sir.
just follow all these vein and you will get the tunnel. So
So
that's why it
basically,
is very
consistent,
important.
constant veins are right gastroepiploic and
Right.
anterior superior pancreaticoduodenal vein. Along with that, sometime middle colic,
Colic.
sometime it will be an accessory right colic vein which will be joining this. And therefore, what you were telling, what at times happen is that when you ligate these veins, you initially you have a tendency that you will ligate the gastroepiploic vein above the anterior pancreaticoduodenal vein. However, the vein entering into SMV would be little lower down. So when you ligate the anterior superior pancreaticoduodenal vein and then you lift up this gastroepiploic vein, then there is good chance that you will go in the right plane with the fascia and then you will make the tunnel easily. So this is one area, and how you control we have discussed. What is the other
Yes,
sites
sir.
of bleeding?
Other
After
can
yeah,
so can be from the pancreatic, the resected board.
before
Uh,
that, before that, go in an order.
You started from the inferior, then the most
Go to
crucial
the
part,
superior.
where you have
Yes, sir.
dissected.
Uh, can be from the GDA also.
GDA. So now
GD.
comes the GDA. So when you ligate the GDA, do you close flush to the CHA or you leave some stump?
So we leave some stump.
Why you want to
Says,
leave the stump? I said you should just plus like it. Why you leaving? What
uh,
is in your
so,
mind?
so usually the patient with the post-Whippers, there's chances the patient might have a pseudoaneurysm, and GDA is the one of the most common
Usual. It
place.
is a usual scenario.
So you are
Yes,
not
sir.
confirmed that you will like it carefully.
Now we clip, divide, and even we take sutures, sir, but we are leaving some stump because if in post-op the patient has a pseudoaneurysm and bleed is
Suppose
there.
there is
So
no length of the vein. What you will do? There is no length. How will you leave the stump? You have a problem. Sometimes you're lucky you have even enough length of the GDA. Sometimes you may not
yes, sir.
have. Sometimes you have a lot of reactions.
So basically, you will answer that in a Whipples, there is a likelihood of pancreatic lead which can lead to pancreatic hemorrhage, and one of the causes bleeding from the GDA. And one of the ways to control this bleeding is embolization or the angiographic technique. So if the stump is there, you will block at the stump so that hepatic artery flow is maintained. And whenever the
Yes, sir.
stump is less, it is good that you do the little lower more dissection
Yeah.
into the pancreas, which will allow you to give a length where you can ligate a little below from the origin of the GDA that is there. And whenever you are having length is less, that means you should always think whether it is getting encased or not. Usually, when the length is less, it is the tumor might be encroaching to that. Okay, what is the third site?
What you could do just to avoid the stump issues? You are doing surgery. You are worried for that that stump could be leak or bleed. What precaution are suggested by the
What
people?
intraoperative step or something what sir is hinting about,
Hmm.
which will help you in preventing post pancreatic hemorrhage?
So momentum we can use. I'm not sure on this, sir, but
So
No,
momentum flap,
momentum
yeah,
placing
yeah,
momentum is
that will.
also one of the thing while
yes,
And
sir.
you do that. Fine. What
and
is the third site of bleeding?
and falciform ligament also you can utilize to cover
Yeah.
the the stump. Yeah.
Yes. Mm, Third would be from while dissecting the uncinate, sir. No,
Before that,
sorry,
you were telling the transaction of pancreas,
pancreas. Yes, sir. From
right?
the pancreatic border, it can lead, sir. So that
So
Cut
that way you have
usually
surface. It
taken
is
the
not the
suture,
border,
no?
it's a cut surface.
Cut
cuts. Yes, sir.
surface also can be.
Okay. And then fourth,
From the jejunal veins. And
so that will be before that if you're talking about jejunum, because before transecting the pancreas, the question was what else you will do? You will divide the DJ and bring it to this side. Then only you will do the transaction, or before that you do the transaction,
no, so after once we have brought to the right side, then
right side. And
yes.
then is the uncinate. So how do you
Yes, sir.
prevent the uncinate bleeding?
So it's
If you have to answer in one line,
meticulous dissection and all the vessels.
meticulous
What
dissection where?
along the
See,
SM lateral border of the SMS and
so
whatever
easily to
vessels.
get away, you should mention the meticular dissection in the mesopancreas.
So,
Understood? Now
yes,
go
sir.
ahead with your
Okay, sir.
reconstruction. Dr. Ashok, any
So,
questions you can ask?
Yeah, yeah, he can continue.
okay. So reconstruction includes either can be pancreatojejunostomy or pancreatogastrostomie. Second is hepaticojejunostomy, and based on the whether we have done a classical or pancreato pylorus preserving, we can go. We have to do gastrojejunostomy or duodenojejunostomy. Okay, sometimes there might be we do feeding jejunostomy along with this after this all reconstruction.
Is there any slide further where you talk about different type of pancreatic reconstructions?
Uh, yes, sir. I have.
Go to that. Okay, you have lot of things here. You have
Yes, sir.
only 15 minutes left. You can
Yeah,
continue
yeah,
according to yours.
yeah, yeah.
Dr. Ashok, the way you want.
Yeah,
Matlab,
yeah.
he has got
I
lot of
think
slides.
he
Yes, sir.
should
I'll just
continue
keep.
because a lot of
Yeah.
things are remain.
Yes.
Yeah.
Sir, anastomosis, like this six, there are six approaches for the artery. First, triangle clearance is one of the new techniques, which basically involves the principle of the mesopancreas resection. So this was in our institute also we are doing on triangle clearance, basic. Then regarding reconstruction part, if we have done a classical Whipples, then it involves the resection of the distal stomach, which includes the 30 to 40% of distal stomach is removed. In that, we have to do the yeah, gastrojejunostomy is done. Whereas if we are doing the pylorus preserving pancreaticoduodenectomy, we do the jejunostomy is done. So outcome wise, the recent study shows the like comparable outcomes in the both kind of reconstructions.
So, what is the benefit of doing the pyloric resection kind of?
Uh, the main concept, initially the classical Whipples included the distal gastrectomy, which was mainly subjected for to removal clearance of the station 5 and 6 lymph node. The recent study shows that there is no additional added benefit in the oncological outcome. And initial studies showed that with this pylorus preserving, there were more of delayed gastric emptying. However, the recent studies mentioned equal and comparable rate of delayed gastric emptying in both cases. So both are
Pyloric
options.
resectional type of the gastrostomy resection. Pyloric resection. What do you think? Pre-pyloric हो गया.
Yes,
You
sir.
have already have said the classical
Yes, sir. Yes,
rectomy.
sir.
What is the
So
pyloric?
in this we are dividing at the pylorus region only. So part of the pylorus is resected,
So what is the
divided.
benefit? What benefit you get? Why this is different from that?
Sir, previously in the pylorus preserving, there was chances the right gastric vessels are likely to be
Go
divided,
ahead.
and
Just
that causes.
read down
Yes,
and just continue.
yes,
Shikhar, basically,
yes,
there were two concerns. One is lymph node clearance, and second was the post Whipple's gastric acid related
yes,
problems. With the advent of
yes,
PPI, that has been taken care. And
yes, sir.
second thing is that lymph node stations people have dissected away. And now when it comes to duodenal division, you divide the right gastroepiploic artery. However, right gastric artery is the only thing which you preserve. But there was increased incidence of DG, which is comparable at certain centers. The other thing was the long-term benefit of the duodenal preservation was better nutritional status in these patients in the long term. However, this was negated by the presence of DGE. That is why people thought we will be preserving little more of stomach.
Yeah.
However,
Yes, sir.
these all are comparable, so you should knowing the difference and you can study them in more depth. Continue.
Yes. Uh, in regarding reconstruct pancreatic this pancreatic stump, we can do either PJ or PG, pancreatic gastrostomy. Routinely, we are doing PJ in our center, that preferred one, and that can be either duct to mucosa And especially if there is a small duct, then we have to go for the invagination or dunking. Then one of the modification in the duct to mucosa is a Bloom-Cart technique, in which we are doing the transpancreatic use sutures we are taking, and then we are going with the duct to mucosa. So these kind of anastomosis subjected to the
Shikhar, why
yes,
do
sir.
you say that when there is small duct, you have to go for dunking?
Not in small ducts, sir. Especially if it is a difficult anatomy, the duct is not identified. So in that
So it is
condition,
the duct is not identified. That
yes,
is
sir.
one absolute indication for doing dunking, whether those who believe in PJ or
वो अभी ना आनंद
whether
जी
they believe in
क्लासेस नहीं
ductal
लगाते हो तुम
mucosa or not.
Yes, sir.
So that is important.
Yes.
Rest all
अरे बस
condition.
सही अब हमारे पास
Yes.
कुछ भी नहीं है करने को ना पहले मजबूरी में करते थे
Hello, sir.
Carry on, carry on.
Yes, sir. Regarding comparison between the pancreaticogastrostommy and pancreaticojejunostomy, again, the early RCT and meta-analysis has showed the lower rate of post-operative pancreatic fistula with pancreato.
See, let's not discuss other studies. Just go on with your practical points here. Okay.
Yeah, yeah.
Yes,
Everybody knows what the studies say, what the meta-analysis says. We
yes,
just
sir.
have to discuss our
Technical point, yes,
practicality.
sir.
You always do PJ or do you do PG?
So most of the time PJ we are doing, sir. Yes, sir.
Is there any situation where you may choose PG over PJ during after a Whipples?
Mm,
This is a practical consideration. Sometimes what happens is you have to do a SMV resection and an anastomosis. The clamp time on the SMV causes
Yes, sir.
the small bowel to become edematous and congested. At
Yes,
that
sir.
point of time, it may help if you can do a pancreaticogastrostomy to
Yes, yes,
avoid
sir.
the congested jejunum,
Yes,
which
sir.
and edematous jejunum, which if you anastomose to the pancreas, may be problems later. That is
Yes,
one
sir.
situation, practical situation. Nobody talks about it, but this is what I have faced and sometimes used. Okay.
Yes, sir.
But for that,
Yes,
you
sir.
have to be conversant with the technique of pancreaticogastrostomy. Because what is the main problem with pancreaticogastrostomy? Post-operatively, what is
Mm,
the main problem?
POPF.
No?
No,
Bleeding, bleeding.
bleeding,
Yes,
bleeding
Bleeding
from the
from
gut.
the
yeah.
PG site is the
Yes,
main
sir.
problem, and it's difficult to control that. So that
Yes,
is the only thing that you should be worried about. Carry on.
yes. Mm. So these are few slides on the post-op management, sir. Like 3, 4 slides.
So how you are doing the HJ?
So HG we are doing continuous using PDS
You are
5.0,
doing
sir.
continuous. Good.
Yes, sir.
So when you decide you're not doing the continuous,
In HG, sir.
yeah. I'm talking about the HJ. Always you are doing the continuous, or sometimes you just need to change your technique.
Uh, so when like dissection we have, if we have done very suppose in very high in near the hilum, in that certain condition we are doing the right interrupted. So, like if the duct division is too high in that condition.
So you may not have enough. Sometimes it's rarely happen with the periampullary, but
Yes, sir.
sometimes you may not have enough diameter. Sometimes you may not have a good condition of the duct.
Yes,
That
sir.
time it's very difficult to do the continued
Okay.
and the continuity with the suture. And
Yes, sir.
sometimes it's situated very deep. So you have a obesity and all the structure require reconstruction are situated very deep. So
Yes, sir.
sometimes you feel it's better to do the interpreted
Yes,
technique.
sir.
That's it. So this could be the answer.
Yes. Uh, so regarding like
And
octreotide,
Ajay, you have
yes.
done the PJ hepatitis. What precaution you're taking when you're doing the what rest the anastomosis left? To what further you do? Do you done PJ, AJ, you just skip on some other
Uh,
thing? Yeah.
Like once we had done PJ, we often put a momentum over the PJs. Our center, we are not using glues. In some centers, like
No,
using a
I am
glue.
not asking. You done the PJ, you have done the AJ, what rest you do? Complete your.
How do you cite the
It,
GJ?
Yeah. I'm just talking.
yes, sir.
How will you decide the?
How do you cite the GJ? Is it anticolic or retrocolic?
Yeah, that I'm
S-
asking. What precaution will take and why?
so, so anti-colic.
Normally
Like
do anticolic, right?
yes, yes, sir.
And
Okay.
supracolic or infracolic? Like
Supracolic,
to
sir.
supracolic.
Supracolic anti. No, no, sir. Through the like infracolic.
So when you do
Yes, sir.
anticolic, you can't do infracolic.
Okay.
It's
Yes, sir.
only in the retrocolic you can bring it to.
You just
To the
try
yes,
to separate the compartments, okay?
yes, sir.
So that
Yes.
whenever the leak occur, it should not affect your GJ and further can
Mhm.
be avoided. Technically, theoretically, you can say that you can avoid the
Yes, sir.
delay gastric empty. So just keep your GJ away from the
Mm.
all these the complex area where you have done your
Then the
yeah
anastomosis.
anosmosis. This is the concept.
Finished.
Yes, sir. Like we usually put two drains, one at the edge site, another one at the PJ site, and once hemostasis has been secured, then we'll do the abdominal closure, mask closure we are doing, and
So
uh,
when you put the drain, is it really you say that edge side? The drain is always crossing the edge from the
yeah,
foramen of Winslow towards
yes,
into the lesser
this
sac,
is
that
fact.
lesser omentum side, because it
Yes,
will
sir.
cover both your posterior part and the edge.
Yes, sir.
Go ahead.
So drain placement is also a very vital part of the procedure
But
when, especially when you have a bad pancreas, you have very soft pancreas, no ducts, you have all suspicion of leak in the post-op. Very
yes, sir.
carefully you should place the drain and try to put the two drain on the PJ side. We cannot
Yes, sir.
say that posterior anterior PJ drain because technically is difficult to place the posterior drain. We can say
Yes,
that the superior PJ drain and inferior PJ drain, so that if there is any leak, should be drained properly.
good.
And
Yes,
one drain for the exit.
yes. And immediate post-operative care requires we follow ERAS protocols in which we go early for the early feeding, multimodal analgesia, early mobilization.
So
POD1,
that
we
can be only be possible when you're doing your surgery minimal invasively. Yeah.
yes,
So आपने इतना बड़ा incision दिया नहीं, you're just saying that the early mobilization you can do, but era is not completed when you have not
we
adapted
open.
the minimal invasive. So better to just learn all this technique
Yes,
and
yes.
so what precaution you take in the follow? How you follow in the first day round? You have operated the patient and what are you looking for?
Sir, in day zero, post-operatively, I look for the patient vitals, hemodynamically, whether the patient is stable or not, is any on any drop support or not. Then, secondly, I look for the urine output, hourly urine output, whether it's coming or not. And then abdomen also will check. Then the drain, amount of the drain, the color of the drain, and then uh, we'll look for the post-op like by blood parameters as well, and preferably we do ABZ on the day zero, also post-surgery, so to look for the all the like stability of the patient. Commonly, we are using DVT stockings in the post-op period for in these patients, and subjective to like in our cases, even in the oral SIPs also we are allowing on the day zero for patients, and day one we try to encourage the patient at least they do standing on bedside, and they do incentive spirometry, and from POD second, usually we encourage patients to walk on the ward. Hello.
Okay. Yeah. Good.
Can we close, sir, now?
Yeah, I
Sir?
think so. Shikhar has done well. I mean, it's a good presentation on his behalf.
Thanks.
And any other comments anybody has? Saluja, Dr. Ashok. I saw Dr. Bharti also.
Dr. Harjeet is also there.
Dr. Weber was also joined.
Yeah, he joined, but he left.
Dr.
He left.
Vyas is there. Dr. Kunal Bharti is there.
ठीक है, do we continue with this kind of a format for surgical presentations? I think we should cut down the preoperative bit and just
Yes, sir.
focus on
I
the
think
surgical technique.
And
on
rest,
that,
yeah.
focus on the this thing. Pre-operative
The tech-
preparation, you were right. That's it, fine. Then after
Yeah.
that, we should focus on the operative technique.
Operative
Operative
steps.
technique and the nuances of the operative technique.
That is the
That should be the main focus, because most of the other teaching sessions will dwell on the other stuff,
sir.
right?
Yeah. Case presentation, you can discuss all these issues, and better to adapt the more pictures, more videos, technical videos, all, and the pictures of the steps. So I think this could be the better presentation. You have done
Yes.
your best effort, but could be the better if you just place,
Yes.
just try to show on the,
Like when you're talking about the PJ or the continuous
yeah.
HJ, if you had short clips, no, video clips,
Yes, sir.
showing those steps, it's easier to understand. You don't have to explain it, you know,
Yes, sir.
that kind of.
That could be the better thing.
Sir,
Okay, then.
next presentation will be by AIMS Patna on case discussion on 27th May. It will be on
Okay.
3 p.m. and Dr. Ashok should be available there, and Dr. Vaibhav and Dr. T.D. Yadav are another moderator.
Absolutely.
Very good day. Good day.
Okay. So,
Thank you.
senior Ashok, sir, or junior Ashok?
No
What are you talking?
Only junior Ashok is there.
Yeah, okay. Okay, that's fine. Okay, thank
Senior
you.
Ashok is not included yet.
Okay, it's less active now.
Thank you, Dr.
Okay,
Saluja.
Okay.
Thank you.
Thank you, everyone.
Thank you,
thank
sir.
you, sir.
Thank you,
Thank
sir.
you. Thank you.